Hello everyone, I am Shweta welcoming you to the Medical and Pharmacy Crash Course Division in the Knowledge Club online. At previous episode, I ended after discussing about the classification of antiarrhythmic drugs. Today, I came with class 1 type antiarrhythmic drugs in cardiac pharmacology. As told before, the antiarrhythmic drugs can modify impulse generation and conduction. More than a dozen such drugs that are potentially useful in treating arrhythmias are currently available. However, only a limited number of these agents are clinically beneficial in the treatment of selected arrhythmias. For example, the acute termination of ventricular tachycardia by lidocaine or of supraventricular tachycardia by adenosine or verapamil are examples in which antiarrhythmic therapy results in decreased morbidity. In contrast, many of the antiarrhythmic agents are now known to have dangerous proarrhythmic action, that is, to cause arrhythmias. The efficiency of many antiarrhythmic agents remains unproven in placebo-controlled random trials. Stay tuned up to the end, don't skip the lecture. If you skip, you can miss a valuable points in between lecture. So I am going to start today's episode. So let's start. First, I am starting with mechanism of actions of class 1 types of drugs. Class 1 antiarrhythmic drugs are characterized by their ability to block the voltage-gated sodium channel. The class 1 agents may block the channel when it is in either the open or the inactivated state. Inhibition of the sodium channel results in a decrease in the rate of rise of phase 0 of the cardiac membrane action potential and a slowing of the conduction velocity. Additionally, class 1 drugs through inhibition of the sodium channel require that a more hyperpolarized membrane potential, more negative, be achieved before the membrane becomes excitable and can propagate an excitatory stimulus. As a result, the ERP of the first response fibers is prolonged. Although many class 1 antiarrhythmic drugs possesses local anesthetic actions and can depress myocardial contractile force, these effects are usually observed only at higher plasma concentrations. The antiarrhythmic drugs in class 1 suppress both normal Purkinje fibers and His bundle automatically in addition to abnormal automaticity resulting from myocardial damage. Suppression of abnormal automaticity permits the sinoatrial node again to assume the role of the dominant pacemaker. The antiarrhythmic agents that belong to class 1 are divided into 3 subgroups with significantly different properties. Number 1, class 1A drugs slow the rate of rise of phase 0 of the action potential and prolong the ventricular ERP, means effective refractory period. Members of this class impair the function of the membrane sodium channel, thereby decreasing the number of channels available for membrane depolarization. Class 1A drugs do not alter the resting membrane potential because they decrease Vmax. Class 1A drugs slow conduction velocity. Members of this class directly decrease the slope of phase 4 depolarization in pacemaker cells, especially those that arise outside of the sinoatrial node. Second type of class, that is members of class 1B, have a minimal effect on the rate of depolarization and are characterized by their ability to decrease the duration of action potential and ERP of Purkinje fibers. Members of this class have a minimal effect on conduction velocity in ventricular myocardium and are without apparent effect on refractoriness. Last type, the drug in class 1C produce a marked depression in the rate of rise of the membrane action potential and have minimal effects on the duration of membrane action potential and ERP of ventricular myocardial cells. Let's discuss about some particular drugs in class 1 type. Number 1 type, that is quinidine. Quinidine is the prototype class 1A drug. Because of its concomitant class 3 activity, it can actually precipitate arrhythmias such as polymorphic ventricular tachycardia, that is Torsades D points, which can degenerate into ventricular fibrillation. Because of the toxic potential of quinidine, calcium antagonists such as amiodarone and verapamil are increasingly replacing this drug in clinical use. Electrocardiographic changes, in this case at normal therapeutic plasma concentrations, quinidine prolongs the PR, the QRS and the QT intervals. QRS and QT prolongations are more pronounced with quinidine than with most other antiarrhythmic agents. The magnitude of these changes is related directly to the plasma quinidine concentration. Hemodynamic effects. Although myocardial depression is not a problem in patients with normal cardiac function, in patients with compromised myocardial function, quinidine may depress cardiac contractility sufficiently to result in a decrease in cardiac output, a significant rise in left ventricular end diastolic pressure and overt heart failure. Quinidine can relax vascular smooth muscle directly as well as indirectly by inhibition of alpha-1 adrenoceptors. The depressant effects of quinidine on the cardiovascular system are most likely to occur after 4 administration. And therefore, quinidine should not be employed routinely in the emergency treatment of arrhythmias because of its potential to cause marked depression of myocardial contractility and to decrease peripheral vascular resistance. Peripheral administration of quinidine is rarely indicated. Then, what is the mechanism of action? Quinidine binds to open and inactivated sodium channels and prevent sodium influx, thus slowing the rapid upstroke during phase 0. It also decreases the slope of phase 4 spontaneous depolarization and inhibits potassium channels. What is the therapeutic uses? Quinidine is used in the treatment of a wide variety of arrhythmias, including atrial, AV junctional, and ventricular tachyarrhythmias. Quinidine is used to maintain sinus rhythm after direct current cardioversion of atrial flutter or fibrillation and to prevent frequent ventricular tachycardia. The pharmacokinetics. Quinidine sulfate is rapidly and almost completely absorbed after oral administration. It undergoes extensive metabolism by the hepatic cytochrome P450 enzymes, forming active metabolites. Oral bioavailability. Almost complete absorption. Onset of action 1 to 3 hours. Peak response 1 to 2 hours. Duration of action 6 to 8 hours, plasma half-life 6 hours. Primary route of metabolism, hepatic active metabolite. Primary route of excretion 10 to 50% renal. Therapeutic concentration, serum 2 to 4 μg per ml. Adverse effect. A potential adverse effect of quinidine or of any antiarrhythmic drug is development of arrhythmia, Torsades D points. Quinidine may cause SA and AV block or asystole. At toxic levels, the drug may induce ventricular tachycardia. Cardiotoxic effects are exacerbated by hyperkalemia, nausea, vomiting and diarrhea are commonly observed. Large doses of quinidine may induce the symptoms of synchronism. For example, blurred vision, tinnitus, headache, disorientation and psychosis. The drug has a mild beta-adrenergic blocking action as well as an atropine-like effect. Quinidine can increase the steady-state concentration of digoxin by displacement of digoxin from tissue binding sites, minor effect, and by decreasing digoxin renal clearance, that is major effect. The contraindications. One of the few absolute contraindications for quinidine is complete AV block with an AV pacemaker or idioventricular pacemaker. This may be suppressed by quinidine, leading to cardiac arrest. Persons with congenital QT prolongation may develop torsades points, tachyarrhythmia, and should not be exposed to quinidine. Owing to the negative inotropic action of quinidine, it is contraindicated in congestive heart failure and hypotension. Digital intoxication and hyperkalemia can accentuate the depression of conduction caused by quinidine. Myasthenia gravis can be aggravated severely by quinidine's action at the neuromuscular junction. The use of quinidine and quinine should be avoided in patients who previously showed evidence of quinidine-induced thrombocytopenia. Next drug is the procainamide. Procainamide is a derivative of the local anesthetic agent procaine. Procainamide has a longer half-life, does not cause CNS toxicity at therapeutic plasma concentration, and is effective orally. Procainamide is a particularly useful anti-arrhythmic drug, effective in the treatment of supraventricular, ventricular and digitalis induced arrhythmias. Hemodynamic effect. The hemodynamic alteration produced by procainamide are similar to those of quinidine but are not as intense. Alterations in circulatory dynamics vary according to the cardiovascular state of the individual. The hypotensive effects of procainamide are less pronounced after intramuscular administration and seldom occur after oral administration. The mechanism of actions. This class 1A drug, a derivative of the local anesthetic procaine, shows actions similar to those of quinidine. Then the pharmacokinetics. Procainamide is well absorbed oral administration. Mind it, the intravenous route is rarely used because hypotension occurs if the drug is infused too rapidly. Procainamide has a relatively short half-life of 2 to 3 hours. A proportion of the drug is acetylated in the liver to N-acetyl procainamide, NAPA, N-acetyl procainamide, NAPA, which has little effect on the maximum polarization of Purkinje fibers but prolongs the duration of the action potential. Thus, NAPA has properties of a class 3 drug. NAPA is eliminated by the kidney and doses of procainamide may need to be adjusted in patients with renal failure. That means the oral bioavailability is 75 to 95%, onset of action 5 to 10 minutes, peak response 60 to 90 minutes, duration of action 4 to 10 hours, plasma half-life 2.5 to 4.5 hours, primary route of metabolism hepatic, active metabolites, primary route of excretion 50 to 60% renal, therapeutic concentration serum 4 to 10 μg per ml. Adverse effect. With chronic use, procainamide causes a high incidence of side effects, including a reversible lupus erythematosus-like syndrome that develops in 25 to 30% of patients, that is lupus erythematosus. Toxic concentrations of procainamide may cause asystole or induction of ventricular arrhythmias. Central nervous system CNS side effects include depression, hallucination, and psychosis. With these drugs, gastrointestinal intolerance is less frequent than with quinidine. Contraindications. Contraindications to procainamide are similar to those for quinidine. Because of its effect on AV nodal and his Purkinje conduction, procainamide should be administered with caution to patients with second-degree AV block and bundle branch block. Procainamide should not be administered to patients who have shown procaine or procainamide hypersensitivity and should be used with caution in patients with bronchial asthma. Prolonged administration should be accompanied by hematological studies since granulocytosis may occur. Third drug, disopyramide. Disopyramide can suppress atrial and ventricular arrhythmias and is longer acting than other drugs in its class. Electrocardiographic changes. The electrocardiographic changes observed after disopyramide administration are identical to those seen with quinidine and procainamide. Hemodynamic effects. Disopyramide directly depresses myocardial contractility. The negative inotropic effect may be detrimental in patients with compromised cardiac function. Some patients develop overt congestive heart failure. At usual therapeutic doses, depression of myocardial function is not a problem in most patients with normal ventricular function. Despite the decrease in cardiac output produced by disopyramide, blood pressure is well maintained by a reflex increase in vascular resistance. Catecholamine administration can reverse the myocardial depression. The mechanism of actions. This class 1A drug shows actions similar to those of quinidine. Disopyramide produces a negative inotropic effect that is greater than the weak effect exerted by quinidine and procainamide, and unlike the latter drugs, disopyramide causes peripheral vasoconstriction. The drug may produce a clinically important decrease in myocardial contractility in patients with pre-existing impairment of left ventricular function. Disopyramide is used in the treatment of ventricular arrhythmias as an alternative to procainamide or quinidine. Like procainamide and quinidine, it also has class 3 activity. Pharmacokinetics. The approximately half of the orally ingested drug is excreted unchanged by the kidneys. Approximately 30% of the drug is converted by the liver to the less active mono-N-dealkylated metabolite. Oral bioavailability 87 to 95%, onset of action 30 minutes to 3.5 hours, peak response 30 minutes to 3 hours, duration of action 1.5 to 8.5 hours, plasma half-life 4 to 10 hours, primary route of metabolism hepatic active metabolite, primary route excretion 80% renal, 50% unchanged, 15% biliary. Therapeutic concentration serum 1 to 5 μg per ml. Clinical uses. The indications for use of disopyramide are similar to those for quinidine, except that it is not approved for use in the prophylaxis of atrial flutter or atrial fibrillation after DC conversion. The indications are as follows: the unifocal premature ectopic ventricular contractions, premature ectopic ventricular contractions of multifocal origin, paired premature ventricular contractions, that is means couplets, and episodes of ventricular tachycardia. Persistent ventricular tachycardia is usually treated with DC conversion. Then what's the adverse effect? Adverse effect of disopyramide shows effects of anticholinergic activity, for example dry mouth, urinary retention, blurred vision and constipation. The contraindications. Disopyramide should not be administered in hypersensitivity to the drug. Neither should it be given to patients who are poorly compensated or those with uncompensated heart failure or severe hypotension. Because of its ability to slow cardiac conduction, disopyramide is not indicated for the treatment of digitally induced ventricular arrhythmias. Patients with congenital prolongation of the QT interval should not receive quinidine, procainamide or disopyramide because further prolongation of the QT interval may increase the incidence of ventricular fibrillation. Because of its anticholinergic properties, disopyramide should not be used in patients with glaucoma. Urinary retention and benign prostate hypertrophy are also relative contraindications to disopyramide therapy. Patients with myasthenia gravis may have a myasthenic crisis after disopyramide administration as a result of the drug's local anesthetic action at the neuromuscular junction. The elderly patient may exhibit increased sensitivity to the anticholinergic actions of disopyramide. Caution is advised when disopyramide is used in conjunction with other cardiac depressant drugs such as verapamil, which may adversely affect atrioventricular conduction. Fourth drug, morphine. Morphine is an antiarrhythmic used to treat documented life-threatening arrhythmias. Electrophysiological actions. Morphine exerts electrophysiological effects that are common to both class 1A and 1B agents. However, it does not belong in any of the existing drug classes. Electrocardiographic changes. The electrocardiographic effects of morphine include alterations in conduction velocity without an effect on the refractoriness of heart tissue. Morphine enhances sinus node automaticity and prolongs sinoatrial and his Purkinje intervals and the QRS. Morphine prolongs ventricular conduction, thereby widening the QRS complex on the electrocardiogram. It has no significant effects on the QT interval. The administration of morphine is not associated with clinically significant hemodynamic effects. The pharmacokinetics. The characteristics of morphine, the oral bioavailability, not known. Onset of action within 2 hours. Peak response 6 hours. Duration of action 10 to 24 hours. Plasma half-life 1.5 to 3.5 hours. Primary route of metabolism hepatic. Primary route of excretion 56% biliary or fecal, 39% renal. Therapeutic concentration serum not established. The clinical uses. Morphine is indicated for the treatment of documented ventricular arrhythmias, particularly sustained ventricular tachycardia. Morphine was evaluated in the CUST-2 clinical trial for the prevention of post-infarction ventricular premature complexes. It was ineffective and found to be pro-arrhythmic. Patients in the morphine arm of the trial exhibited a greater incidence of sudden cardiac death than did controls. Adverse effects. The principal adverse gastrointestinal effect of morphine is nausea, 7%. Abdominal discomfort has also been reported. Dizziness, 11%, is the most frequently reported CNS-related adverse effect. Such reactions increase in frequency with prolonged drug administration. As with other antiarrhythmic drugs, morphine has pro-arrhythmic activity, which may manifest as new ventricular ectopic beats or a worsening of pre-existing ventricular arrhythmias. These effects are most common in patients with depressed left ventricular function and a history of congestive heart failure. Cardiovascular effects requiring drug withdrawal include conduction defects, sinus pauses, junction rhythm, and AV block. Contraindications. patients with pre-existing second or third degree epilogue, cardiogenic shock or drug hypersensitivity should not be treated with morazosin. So, today we learned about class 1A antiarrhythmic drugs action to treat arrhythmias. I discussed one modern type of drugs also in pharmacological relevance. I will come at the next episode with rest of the part of class 1 type antiarrhythmic drugs. Revise the all episodes on heart thoroughly. I made it step by step accordingly. Here the all previous episodes list on heart anatomy and physiology chapter and cardiac pharmacology chapter. You will get all links at discussion part of this video, or you can visit our channel. Before ending today's episode, if you like this video, please like, share and comment freely. Don't forget to subscribe our channel. If you already subscribed, then thanks a lot. And after subscribing our channel, please click on the bell button for getting the regular update. I am coming with another episodes very shortly. Till then, goodbye.